My name's Kristina Chapple. I am responsible for supporting research, mostly in the trauma department, kind of trauma and beyond here at St. Joe's. I'm going to talk a little bit about research today. And one of the most common questions I get is basically like how to understand statistics, how to read a journal article. Students and residents are sometimes looking for very practical advice. So I think I'm just going to speak to that for a bit. And if anybody has questions along the way, feel free to jump in. So research participation, the way I kind of see it is, I think we all have an obligation to be able to understand a manuscript, especially in your specialty area. And then beyond that, some of you might choose to participate in a retrospective study, maybe a prospective study, or even get your own grants. So today we're going to focus on understanding the manuscript piece for people who are not statisticians. So when people ask me, what is the key to understanding statistics? I say, don't focus so much on the statistics. And what I mean by that is in a well-written article, the tables and figures will tell your story. So instead of focusing on the stats, allow the tables and figures to tell your story.
Slide.
That's not giving us this.
Okay, so is it, you confirm that we can? If people are not seeing the shared PowerPoint, if somebody could text Tammy, that'd be great. I think we're good. Okay, so I'm going to go ahead and keep going. So as you probably are aware, the manuscripts, the way manuscripts are organized is almost always in the same format: abstract, background, methods, results, and discussion. And for my talk today, I'm going to be focusing on tables and figures that I said methods, but they're generally in the results section. So this is how I approach an article, especially because I don't have a clinical degree. A lot of times the science, the medicine behind the article is something that I don't catch on to, I don't grasp without somebody really telling me what's going on. So here's kind of how I approach things. And I kind of want to make a game out of it today. So I think what we can do is, if you are able to go through the tables and the figures, you should have a really good idea of what the title of the paper is. And when you first look at a paper, one thing you're going to know about it is where was it published and the title. I'm not giving you the title because we're going to guess it, but we're going to see where it's published. So the article that we're going to talk about was published in the Journal of Trauma and Acute Care Surgery. So there's our first clue. And now what I'm going to do is, without telling you what article we're reading, we're going to go through the tables that are published in this paper. And then you're going to guess what the title of the paper is. Okay. So this is table 1. And I see it's a risk profile score. So when I look at this table, I just kind of want to think about, what's this table trying to tell me? What am I learning from this table? So I can see that these patients are going to be assessed for all of these things, and they're going to be assigned points for depending on the category that they fall into, right? So is this a pediatric paper? If I look through this table, what do I think?
No.
Yeah, definitely not, because my age categories are from 40 to 60, 60 to 75, 75 plus, right? Would I think this is a family medicine paper?
Yeah.
No, what, how come?
This is a trauma paper.
This is a trauma paper. So we know from
There are numbers.
Yeah.
we know from from where it was published, we were published in the Journal of Trauma, but also I'm looking at body injury severity scores.
Yeah.
So I'm seeing that this is a trauma paper. These patients are injured. These patients are adults. So injured adults is who we're looking at.
Okay.
I go to table 2. So I still don't know. I don't know what the paper's about. I don't know the outcomes. I don't know the independent variables, but I'm looking at table 2 and I see that there's an ultrasound group and a no ultrasound group. It's a big study. There's almost 1,000 patients in each group. And I'm noticing there's a bunch of p-values there. And what I know about p-values is that the significance threshold is usually set to 0.05 or below. So if I go through all of these indicators under variables, which ones are significant? None of them. In a table like this, I'll tell you, we want to confirm that our groups before the study at study start are equal. So in a randomized control trial, our p-values should all be above 0.05 at the beginning of the study. And so here, what I have is there's no difference between groups in age, gender, injury type, BMI, GCS. And that this also continues to give me a clue about what we're studying. If I look down, I see IVC filter placement, I see major bleeding. So I see spinal cord injury. It just gives us more and more clues about what we're studying. If I go to table 3, the title of table 3 says mortality outcomes comparison. So that's the first clue that I've gotten in this paper so far on outcomes. So what are my outcomes for the study? PVT, PE, and mortality are my outcomes. So that's what the investigators are interested in. And then what are my groups? Ultrasound versus no ultrasound. So something is going to be about an ultrasound versus no ultrasound group, and my outcomes are PE, DVT, and mortality. So I'm starting to get a little bit of an idea of what this paper is about. And I haven't read anything yet. I did not read the abstract. I didn't read anything. Now, table 4, I can see they've gone into table 3 and they pulled out DVT, and they've expanded on DVT in table 4. As you can see, those numbers line up together. So that's how I figured out. And so they're giving you the characteristics and management of DVT subjects by study group. Still haven't read the paper. And then same thing, I have table 3 on the left, and then I'm going to show you what they've done for table 5, which is the same thing. They've pulled out pulmonary embolism, and they're going to expand on pulmonary embolism. Now, if I go back to table 3, is there a statistically significant difference between these groups? Table 3. So my threshold is less than 0.05, and that's my p-value. So what is statistically significant, and what's the direction?
A lot more difficulty using cheese in the non-ultrasound group while in hospital.
Yes, and that's statistically significant. Overall, are there a lot of DVTs and PEs in these patients, or is it a rare event? it's a rare event. However, it is statistically significant. At 90 days, is it significant? No.
No.
So in hospital, yes. 90-day follow-up, no. What about DVTs? Were there more DVTs in the ultrasound group or the non-ultrasound group? The ultrasound. Yeah. And was that statistically significant? Okay, yes. For the sake of argument, we'll say yes. It's right at 0.05. What about the direction? What do we notice? So we've got 1.9%. So that's the higher group. So the direction switched, right? So for DVT, we had more in the ultrasound group. For PE, we had more in the no ultrasound group. Almost like if you go looking, you're going to find them, but then the PEs are actually lower. Talk about that. For this paper, that's all the tables that they give us. And now I want to go to figure 1. Figure 1 is a flow diagram. And the first word I see in figure 1 is enrollment. What do I learn from that? What does that tell me? What's that tell me about the study design?
Prospective.
It's a prospective. So this is not like a retrospective chart review taken from the trauma registry. This is a prospective study. Is it a pretty big study or a pretty little study? Pretty big study, yeah. And why do we need so many patients? Power, because we have a rare event. Good, thanks. So we've got over 3,000 patients assessed for eligibility. We've randomized over 2,000. And that's where we get our 1,000 for the no ultrasound group and 1,000 in the ultrasound group. And then we do our analysis. So when you see it, I think it used to be more that when you saw these figures, that for sure it was a randomized control trial. Now I feel like we're being asked more and more to even give a flow diagram for our retrospective chart reviews. It's just kind of an easy visual to see you know, how we arrived at our sample size pretty much. Okay, so if I think about what we just saw, and I'm going to try to guess our title, we're going to use the strobe, our strobe methodology to guess the title here. And so according to strobe, a good title for the study will have the study design, what was done, and the outcomes. So given the tables and the figure that we just saw, what can we come up with?
Yes,
Good. It was tasty, wasn't it?
it is.
I think, and that was 8.5. So not bad. So now that I'm getting us more free money for food, we make it kind of impressive every once in a while.
Yeah, I think it will be very popular.
Yeah, it seems to be very popular. I can't, I'm so sorry. Whoever's talking, I can't tell if you guys are answering the question or if you guys are having another conversation. Okay, I'm gonna guess another conversation. Okay, so study design, what do we say? Retrospective or prospective? Prospective. What are our groups? Ultrasound, no ultrasound. What was the outcome? And what direction was it? Were there more PEs in the ultrasound or no ultrasound group?
Hey, right, oh, you sound great. You don't. Yeah. I'm not quite there yet. Yeah. What do you think it was?
Just a cold. I tend to get hoarse when I get cold from this one. Just got it.
Thanks for covering last week.
No.
think our table's the only one.
If you're on Zoom, please make sure that you're muted.
Okay, I was going back to this table to help you guys. So there were more PEs in the no ultrasound group. Now, without reading the article, without looking at the abstract, what is the plausible title for this study? Maybe we start with study design, like a prospective randomized controlled trial comparing what? What's the intervention? On what, and then what would our outcomes be?
Acute trauma.
That's good in trauma patients. And what's the primary outcome? Yep. PE or DVT. So all of those pieces that we just gleaned just from the tables and the figure alone really do kind of put together the title of the paper. And we kind of have a really good understanding of what the paper's about and what the results are, what the outcome is. And we didn't really talk about statistics. We talked about groups, we talked about this big sample size, but we didn't talk about chi-squares or t-tests. We were really more focused on study design. And so my advice when trying to understand the statistics is to first focus on the tables and the figures and get the story from the tables and the figures, and that will kind of lead you down this path as to what the study was about and the outcomes. And then later you can dive into, if you really want to understand, well, how did they compare those groups? Then you can go to the methods section and the results section and get a very clean understanding of how they compared our groups. Questions? All right, if there's no questions, then Dr. Curtis is going to talk to us about research processes at Valleywise, which are in many cases shared with Joe's.
Thank you, Dr. Chapple. I do want to be sure and formally acknowledge that Dr. Laura Nordstrom provided the slides that relate to Valleywise. She's the director of clinical research at Valleywise. So if you do research over there, you'll probably cross paths with her a little bit. And I'm a little tempted. I get a sense that you guys maybe would rather have me discuss the assumptions and nuances of using the general linear model for doing your regressions. Is it okay if we shift gears and do that? Crowd. So the principles that I'm going to talk with you about are really apply both here and at Valleywise. There are a few differences in some of the processes for getting studies approved and for tracking studies at the different campuses. But really, to start with, have a research question. Every project, every research project, every eventual paper starts with a question. And it can be just about anything. And in your case, is probably anything that's clinically relevant. Answering some questions will lend, projects that answer some questions will lend themselves more to clinical trials that might require grant funding, that might be beyond the scope of what you could do as a resident or as a medical student. But think of those questions anyway, even if it's something that you have to put off until you can get grant funding later. Think of questions. Many of them can be answered just by reviewing medical records, hopefully digitally, hopefully not reviewing them all manually and abstracting. That's quite tedious. But start with a question and then talk with a mentor. preferably somebody from your department, because chances are the questions you come up with are going to be relevant to the department you work in. Find somebody in your department that can be a mentor and work with them. And then if you're at Valleywise, contact the departmental research manager. I would recommend strongly when you start trying to figure out how you want to answer your research question and start writing up your protocol, doing your research design, talk with a statistician early on. That makes a difference. I believe most statisticians would rather be involved early rather than get the data late and realize that the data is maybe worthless for trying to answer the question that you're interested in. If it's just really basic stuff, I'm happy to help you. If it's more difficult stuff, I know Dr. Chapple is extremely busy, so I won't volunteer her for all of your projects. She's really good, and you might be able to just bounce an idea off her and she could send you off to somebody else. Now, we're limited in the number of statisticians that we have available, but your department chairs have access to funding that they can use to contract with statisticians externally. They may not know that. If they don't know about it, please direct them to me or direct them to Dr. Dan Gridley, who is the Assistant Dean for Clinical Research and Public Health here in Phoenix. He can help direct them and help them understand how they can use their chair funds to contract with a statistician. But for some projects, you may not need a statistician. And again, I'm completely willing to help you navigate that process if you need it. My name's Jeff Curtis. Don't use my Creighton email. I don't have access to it, but Jeffrey_Curtis at DMGAZ at District Medical Group. I'll just there. So then there's an IRB process. St. Joe's has an IRB and Valleywise has an IRB, and they're separate. And actually Creighton has an IRB too. They need to be notified about your project, but they're not the primary ones that do most of your projects. We will eventually have a more defined roadmap for you to follow. But for now, if you're getting clinical data from one or the other of the sites, you need to go through that site's IRB to get approval. Yes. No, not really. The question for those of you who are on Zoom is, in addition to getting the site-specific IRB approval, do we also need to get Creighton IRB approval? Not really. There are agreements between the site IRBs and the Creighton IRB, and the Creighton IRB will accept the approval of the site IRB, but they need to be notified about it. That will generally not be your responsibility, but I want you to be aware that it's happening. Creighton is required to track the research projects of all of the students, and I believe residents as well, since you're technically employed by Creighton. And so they need to be notified, they need to be aware that it's going on, and it needs to be logged with their IRB as well. I'm probably making all kinds of mistakes in what I'm telling you, but that's what I believe is the case right now. Did you have a follow-up question? Yeah, we'll get to that as well. For the clinical data studies, you'll need to get REDCap approval and establish a REDCap account with that facility. If you're using Dignity data, you'll need to get a Dignity REDCap account. If you're using Valleywise data, you'll need to get a Valleywise REDCap account. Both sites have them. They both have contracted with REDCap, and they require that clinical data be kept in REDCap. I believe the only exception is if you were doing a multi-center study, and if that study had made arrangements already to use some different data capture, data management software package, you could store it in that one, but it would have to be HIPAA compliant and secure and all that stuff, which REDCap is. So part of the process for getting approval, if we back up a little bit, if you're at Valleywise, you get on Axiom Mentor. You can email the IRB at the email address here, just irb@valleywisehealth.org, and they will give you approval to get on Axiom Mentor. Axiom Mentor is the software package that Valleywise uses to track projects as they go through the IRB approval process. Dignity uses iMedris. So difference in software, but the principle is the same. Each site has a software package that they use for tracking projects through approval. And I believe at both cases, you'd be required to provide this documentation. Each site or either site, wherever you're doing your project, You'll need to have documentation of your city training. I hope you all know what that is. The city program is the standard online human subjects protection education module that everybody has to go through. I would recommend that if you're interested in doing research at all, the first step to do right now, before you even think of a research question, do your city training. You can log on to cityprogram.org and sign up as I would recommend that you affiliate yourself with Creighton University and with Valleywise Health and with Dignity Health, because then you'll be automatically assigned the modules that you need for each of those affiliations. It's completely beyond my control and completely beyond the control of anybody who works for the IRBs at any of those sites. It will take you longer than you think it will. So I would recommend doing that right now. Do a little bit here and there, just try to get it knocked out as soon as you can, because then you'll be ready and that won't be a hurdle when you've come up with your research question and you want to get it approved and get started on the project. So either site, either St. Joe's or Valleywise, will require documentation of your city training, assigned and dated CV, and assigned and dated conflict of interest form. They use slightly different forms, but they're easy to do. Dr. Chapple.
And one thing about that cityprogram.org site, you will have one account for what the rest of your career. So don't, when you go somewhere else, don't make a new account. You need to figure out your login, get in there and reaffiliate yourself. I made a second account once and it was a nightmare. So don't do what I did.
So, for those of you who are on Zoom and didn't hear, Dr. Chapple said, your city program account will stay with you for the rest of your life. I'm going to keep from making a stupid joke. It will stay with you the rest of your life. You change your affiliation and add other affiliations as you go through. So don't make a second city program account. If you've already got one for Dignity, don't make a second one for Valleywise, just add the affiliation. Okay, and then medical students, if there are any paying attention to this, at Valleywise, you're required to be granted adjunct research associate status, which requires the same stuff that I mentioned on the last slide, the city program documentation, an updated CV, and a conflict of interest form. But in addition to that, you have to provide evidence of vaccination, and they do a background check. That's already been done for the residents, so they don't have to go through all that again. And when you've done all of that, you'll get access for the students, if you're not already a third or fourth year student and have access to the EMR, if you're a first or second year student, that will get you access to EPIC and to REDCap once you've been deemed an adjunct research associate. Now, what we generally lump all together into the IRB, everybody talks about approving or submitting their project for IRB approval, and it takes forever, and it's a really cumbersome process, and everybody hates it and stuff. Technically, there's an IRB proper, the Institutional Review Board, and then there's a broader process that involves more than just specifically human subject protection review and approval. The Institutional Review Board is really only concerned about human subject protection, and they review the project by some defined criteria to determine if human subjects are going to be adequately protected. But there's also contracting, scientific review, feasibility, lots of other things that are done that we conceptually lump in with IRB review. All of those other things have to be done and approved as well. And if you're going to be sharing data, say you want to do a project that involves data from Valleywise and from Dignity, you want to merge the data together, there will need to be a data use agreement for your project. That's all part of the approval that needs to be done. There are already kind of large scale data use agreements, but the individual project has to be for merging the data and you sharing the data between the two sites prior to conducting the study. So research, scientific review, compliance, legal, risk, all of review has to be done. Now, a question that comes up is, why is it so difficult to get projects approved at St. Joe's, particularly compared with Valleywise, but in general, why is it so difficult to get approved at St. Joe's? And my understanding of that difficulty is that St. Joe's has has created an incredibly robust, well-designed research infrastructure that's primarily focused on funded pharmaceutical and device trials and things like that. They have an exceptionally well-developed program for approving and tracking and monitoring all the contracts and stuff for studies like that. That makes their process more cumbersome at the level of resident or student. But it doesn't, your project doesn't have to go through all of the approvals for each of the areas that would be required for a funded pharmaceutical study. But still that infrastructure exists, and at least kind of boxes have to be checked off to indicate that you don't require a contract review and that kind of thing. So it's not that St. Joe's does a bad job. In fact, I think they do a really good job. They just have this incredibly well-developed process and organization that's well suited to funded trials. So part of it is you have to develop the database. If you're at Valleywise and you're going to use patient data, they have to create an IT report that gives you the data that you need, the raw data to do your analysis. And they have to set up a REDCap account that's specifically appropriate for those data. So there's a lot that has to go into it that they'll do for you. They won't let you do your own programming to extract the data. They've got people who can do that. The people who do that are extremely busy. So give yourself a lot of lead time. It might take a few months for them to write the reports and pull the data for you. And they might generate a sample report and show it to you and say, is this what you need? You might need to tweak it a little bit, do it differently and have them redo it. That takes time. So try to give yourself lead time. It is not reasonable to start a project today and think I'm going to have data 2 weeks from now. It just takes longer to get the approvals done, get the reports written, get your REDCap account set up and the specific variables defined and stuff. And even IT security has to be a consideration. The IRB review itself is focused only on human subject protection. Submit your project. It might have to go to the full IRB. It might be granted an expedited review status. It might be exempt. The IRB might determine that it's exempt. They give it a stamp of approval and you don't have to do ongoing approval after that. We don't have time today to go through each of the criteria for each of those different statuses, but it also might be deemed not human subject research, which most of your QI projects would be. Most of the time, a QI project is deemed not human subject research by a very specific federal regulation definition. And if it's not human subject research, you don't have to have ongoing IRB approval. But if you're doing a QI project and you anticipate presenting or publishing it, you'll still need to have the non-research determination letter from the IRB in order to submit your data for presentation or publication. So even if you're doing a QI project, please submit it for review. And that determination about whether it's human subject research or not, or whether it could be approved in an expedited fashion or needs to go to the full board or whatever, at least at Valleywise, is done by an administrative review committee that meets on Wednesdays, et cetera. And we won't go through all the details of this in the interest of time, because I know Dr. Chapple has more she wants to talk with you about. If you need information on specific people to get in touch with, reach out to me. I'm happy to steer you. Dr. Nordstrom, I'm sure would be happy to steer you as well. She knows the infrastructure at Valleywise far better than I do. She is the director of that program, and she's very approachable and easy to work with. But here are some names of some of the folks, and we likely will end up having this posted on someplace on the Creighton website, so you can come back and look at individual names for contacts. I think that's all I've got about Valleywise specific, hopefully some principles that apply to both places. Do you have any questions for me before I shut up and sit down? Yes. Okay, so the question is, how do we get the project uploaded into RedCap? That might be different at different sites, and you may want to address that when you start. What I've done in the past is I receive a data file, and I guess in some cases I've actually received it already put in data, put in RedCap. In other cases, I've received a report that lives in Epic, and then I just export it from Epic into RedCap. But I've had to have the RedCap file already created so that RedCap knows what fields are coming in. You may have different experience and be able to explain that better, but you might have to do some importing or you might just receive it in RedCap already.
So is it that somebody supported for RedCap? Is the data feeds?
You will work with people from IT at either campus, and they'll help you in making that. Please let me know if I'm steering wrong on that with regard to dignity.
So at St. Joe's, are you just gonna leave me?
Yeah,
Okay, we're good. For RedCap at St. Joe's, I will get to my. Oh, shoot, I don't know where it is. There's a link. So if you're going to do research at St. Joe's, there is a link to a survey that you complete to get a RedCap account. Once you get the RedCap account, you can go in and create a new project. There are tons of RedCap tutorials. So I look things up all the time if I need to know how to do something. But basically the shell that Dr. Curtis was talking about. So if I have, let's say I'm importing data from the Toronto Registry, I might be importing 20 data fields, and it might be age, gender, BMI, ISS. I tell RedCap field 1, all of these things. I'll suck all that data in, and then I'll modify it to say, okay, now my chart review is going to look at CT findings, surgical notes, whatever else I'm going to add. So then I'm only doing my chart review on, what we couldn't export from the registry or from your EHR. Is that clear? And so, yes, you can do it, or you can work at St. Joe's anyway. You can do that on your own, or you can work with like a research project manager that works for research administration, and they can help you. It's not difficult at all. Okay. Dr. Curtis already talked about the city program. Here's the URL to the city program. There's my name, there's my ID. It'll ask you a series of questions. One thing I like to tell people is if you can add on modules that are not required depending on the way you answer these questions. So just keep that in mind. Here at St. Joe's, you're going to send your certificates to Kim Hedden, and there's her email there. Along with your CV. And then an iMedris account. If you go to this URL up there, dignityhealth.imedris.net, here in pink, you click on this button to request a new account. You're going to be asked some information, and then you submit it. Once you request that account, they're going to look at just to make sure that you've got all your requirements completed. So you're not going to be given an iMedris account if your city training has not been complete. So you're also not going to be able to be permitted to be added to a research study if all of your requirements aren't complete. Here's the slide I was looking for. The URL to request a RedCap account is here. And there are a few people in IT that approve those accounts. Once you submit it, it takes just a day to a couple of days for them to approve it. So once you submit it, be looking for an email back. And then this is just a snapshot of what my RedCap looks like. There's a few project titles. So if I was going to start a new one, I would go here to new project, and then I could start building out my RedCap. Questions on the Joe side so far? There's one more thing I have. So at St. Joe's, the conflict of interest form is now a Koali form. If you have not been, if you've not completed the quality conflict of interest, you will not be able to be on a research project until that's complete. To have them send you the information, you send an email to this, this link above, synapsesupport@veroneuro.org. And I think they only import those like once or twice a week. So you probably have to wait a few days and they kind of send them out in batches. You're going to be asked to disclose just about everything about yourself and your kids and all that you've ever thought. And again, this is something that's out of our control. If you are teaching at a university, if you're at many, many hospitals, it's a government thing, not a St. Joe's thing. So it's not that our research administration department is trying to be big brother on what you have to disclose. If you disclose nothing, it will be automatically approved. If you disclose something, then it will be routed to like a research administration manager, and they can either just approve it right away, or if they foresee a conflict, then they would bring it to, I think, the research director. Yes.
Question about the red cap.
Hmm.
So you need to have the project built before submitting this for IRB approval?
No.
No.
Red cap, you don't need a red cap account to actually go through the IRB process. You can go through the IRB process, and then after you're approved, then you can work on your red cap. And I'm happy to point you in the right direction with the red cap, or sit with you for a bit and help you do that. Who in this room has been through all of these IRB requirements? Anyone? One, okay. Two. All right, well, I think they're going to make these slides available. Again, my name is Kristina Chapple. I'm here at Joe's, Dr. Jeff Curtis. And that's it. Thanks so much.
Ask if, before we wrap up, just ask if Dr. Nordstrom has anything that we left out.
Oh, Dr. Nordstrom, are you still there?
Yes, I'm here. Hi. I don't think so. You know, our red cap process is very similar to yours, Dr. Chapple over at St. Joe's, and Dr. Curtis, you did a great job of describing our process over here. And like he said, it's fine to contact me first if you have questions. We also have department-specific coordinators that are great resources for any of this.
I think on our side, the one thing about red cap that gets me sometimes is that when you build it, you're in development. But before you start doing your chart review, you're supposed to put yourself into production, and you have to request to put it into production, and then you have to add your OSPR number and a little bit of proof that you've been through the IRB. When you do that, you need to let them know that if you have data imported from a registry or something that you did not have to do chart review on, you need to let them know not to wipe that out. So what I do, because losing data is so painful, is I make a copy of that in red cap, just in case by accident it gets deleted, and then I delete that copy later. And I don't know the answer to that question, Danielle. Any other questions or comments? All right. Do you guys need to say anything else, or are we adjourned? Now, the question was, how did they get to that QR code?
So did they just, yeah, all they have to do is scan it.
Okay.
Okay, thank you.